Respected teachers, dear panelists, and learned audience, welcome and Assalamu alaikum. Me, Dr. Muhammad Abu Talha, registered pediatric cardiac ICU of National Heart Foundation Hospital. Welcome to my article presentation on Ivabradine, a game changer in post-surgical junctional ectopic tachycardia. Junctional ectopic tachycardia is an abnormal tachyarrhythmia that originated in the AV node or high in the His-Purkinje system. The incidence is around 5 to 12% and most commonly occurred in early postoperative period after repair of VSD, AV canal defect, TGA, and tetralogy of Fallers. Almost jet is self-limiting, but may causes significant hemodynamic instability, even death, if not managed aggressively. This is the hyperpolarization cyclic activated nucleotide channel. This is responsible for conduction of sodium and potassium through the plasma membrane and excess production of funny current that is generate jet. And if any abnormal stimuli that activate more cyclic AMP system that produce more funny current and produce more jet. Ivabradine selectively blocks this nucleotide channel and reduce production of the funny current, ultimately reduce abnormal automaticity and reduce or terminate jet. The experience on Ivabradine used in pediatric population is very, very limited. And here we shared a 15 patient case series of post-surgical jet that was successfully managed by Ivabradine. This is a case series in January to December 23, 15 post-surgical jet managed by Ivabradine with good outcome. All pre and post-operative variables, disease complexity, and surgical procedure, any rhythm abnormality, and onset of jet, and doses, response, and adverse effect of Ivabradine were documented and well recorded. In our ICU, all patients obtained a 6-lead ECG and transthoracic echocardiography also done to see any cardiac abnormality or cardiac function. If any child having any suspected lead rhythm abnormality, then another 6 lead ECG, including atrial wire ECG, are done, and the ECG are reviewed by pediatric cardiologists to confirm the diagnosis of jet. And jet is confirmed by when a child having heart rate more than 95th centile with narrow QRS complex, atrioventricular dissociation with ventricular rate faster than atrial rate, and 1:1 ventricular atrial conduction, POF after QRS complex, or POF merging within the QRS complex. This is the 6-lead ECG of a post-operative patient. Here we see that the QRS complex is narrow and heart rate 140, that is more than 95th centile of the age of the child. And we also see that the red dotted QRS complex followed the blue dotted POF. And the atrial ECG with confirmed that ventricular associated ventricular atrial dissociation by retrograde POF after QRS complex. After diagnosis of jet, we manage the child by provide adequate analgesia and sedation, avoid hyperthermia, and also correct hypovolemia, acidosis, electrolyte imbalance. And we also try to reduce the doses of catecholamine as low as tolerated the child. Though amiodarone is the first line therapy for management of jet, but it is a negative inotropic agent and also having few adverse effects in pediatric population like extreme bradycardia, hypertension, even sudden cardiac death. For that, we searched several articles and found that recently few published data showed Ivabradine have promising positive outcome for the management of junctional tachycardia, and we switch our protocol from imidazole to Ivabradine and started Ivabradine to 0.05 milligram per kg per dose for 48 hours after total 4 doses. Now the results. Total 93 congenital heart surgery were done. Among them, 14% developed JET and incidence were 1.53%. 60% were male. And most of the children under 5 years. And we found that more than 90% having congenital heart disease, cyanotic heart disease. Among them, 11 were TOF, rest of them TGA, pulmonary atresia, DORB, VSD, and PAH. The median CPB and cross-clamp time were high, heart rate 180 beats per minute, and 4 child having 2:1 heart block and 1 sinus tachycardia. The table showed that mean time of onset of JET after surgery 30 hours, lowest time 1 hour, and maximum 93. And we started initiation of Ivabradine within 3 to 4 hours of onset of JET, and mean time for response of JET 7.9, and conversion of sinus rhythm about 15 hours. In our study, we found that 100% patient response to Ivabradine, but 1 child having bradycardia that was successfully managed by temporary pacemaker. 2 patients had recurrence of JET that also managed by additional dose of amiodarone. But most of the child discharged to home. Unfortunately, 2 patients died. But their mortality is not due to Ivabradine or any arrhythmia, because the 2 child presented very lately in our center and having very prolonged ICU stay with STROMI ICU event like prolonged duration of mechanical ventilation, ERDS, AKI, needed peritoneal dialysis, ultimately developed culture positive sepsis, septicemia, and septic shock. So, the study concluded that Ivabradine is more targeted therapy for post-surgical JET management, and Ivabradine is also shown safe and effective alternative of to amiodarone first management of JET, and more larger study including RCT to be needed for rationalize the doses of Ivabradine in pediatric population. Now the take-home message. Ivabradine is well tolerated and have promising positive response to post-surgical JET management after congenital heart surgery, and early administration of the Ivabradine therapy as soon as JET is identified will play a key role to prevent hemodynamic instability and mortality. Thanks all, and thanks for patience hearing.
Thank you, Dr. Talha.